Thank you very much for inviting me to be here. I'm delighted to be here. So today we're going to be doing different things. We're going to be working a little bit more in groups in the afternoon. But at the beginning, the first session is going to look at how does participation work? How do patients and communities who participate, how can they influence what they are doing? How they can have an impact? So we are going to step out and look at participation from the outside to critically understand how participation works in practice and how participants can influence what they are doing when they are participating. So we're going to look at some of the challenges that they encounter when they are participating. Which barriers do they encounter when they are trying to raise their voice, when they are trying to represent other members of their community, when they are trying to contribute with their lay knowledge, which challenges they encounter when they are working with professionals, researchers, and healthcare providers during participation. So as we're going to be working together, I thought we have an icebreaker first. So I don't know how much you know each other. And also, is this like the tool for moving the slides? Yeah, okay, great. Okay, so before we start, I have some sweets from the UK, and I want you to take as many as you want. Okay, so I'm going to pass this around, and then take as many as you want, and then I'll tell you what we'll do, okay? So we're going to start now thinking about participation, but from the outside, okay? So I'm going to talk about a study we did. It was a 4-year ethnographic study looking at how can patients who are participating in healthcare research and healthcare improvement activities in the hospital, working with researchers and clinicians to try to improve services, how can they have an impact in healthcare? And we were trying to understand what works when patients participate, why and how, okay? So Cecily and me, Cecily is a professor at the London School of Hygiene, and we worked together in this project, and we were aware that there were a lot of publications looking at describing participation and how patients participate, but not so much looking critically at whether they have an influence and why they might not have so much influence when they are participating. So we decided to do an ethnographic study and to look at different aspects of participation from a very sociological approach. And I'm going to go through what we found with regards to participation. So what I did is, I don't know if you know what ethnography is, but it involves observing what you are trying to research and understand. So I spent 4 years in the hospital observing how patients collaborated with healthcare providers and researchers, researchers, in activities to improve care pathways and quality of services in the national health services in the NHS. So I conducted observations, and I also interviewed patients who were participating and community members who were participating in these activities, and staff or professionals, that is healthcare researchers and providers, clinicians and nurses who were working together in teams with patients to improve services, and they were doing research together. So we were looking at what works, why and how when patients participate and collaborate with researchers and healthcare providers. So the context of the research was a consortium called CLARK, Collaboration for Leadership in Applied Health Research and Care, and is an ambitious project that tries to enable collaborations between patients, healthcare researchers, and frontline staff in hospitals, so that they can use quality improvement technologies and tools to improve care pathways. So for example, the way patients were participating was through research projects where they were trying to design new care pathways. They were trying to, for example, collect information about how services were working, and then they were reflecting with professionals. And when I refer to professionals, these are researchers and providers. They were thinking about how they can improve, how they could improve care. I wonder whether maybe it's good. It's a quite complex consortium, and the context of my research. So I thought maybe it's good for you to see a little video of the research, so that then you understand where I conducted my research. So I have it here. I'm just gonna play. So this is where I conducted the research. This is where I looked at how patients were participating.
Over the last 5 years, NIHR Clark and North West London have built a strong foundation of practical and academic expertise in the translation of research into practice. Our aim is to enhance quality and value of care, promote the importance of patient experience, and support the improvement of health outcomes.
The translation of research into practice and the development of academic improvement science expertise is critical to Imperial College's ambition as an international centre of excellence, redefining medicine and health for enhanced patient care. Clark very much acts as a broker across North West London, bringing together our academic faculties with healthcare organisations, patients and industry. This empowers these stakeholders to play a critical role in the NIHR pipeline.
Healthcare is complex, involving different individuals, professions and organisations, and influenced by multiple sources of research evidence, guidelines and policies. The effective implementation of research into practice requires rigorous processes of investigation and flexible infrastructure that recognises context and fosters an ongoing culture of improvement. We need to focus on what actually happens between frontline professionals and patients. We developed a systematic approach that brings together patients, healthcare professionals and academics to work scientifically and use a suite of quality improvement methods to deliver measurable and sustainable benefits. This wasn't straightforward. At first, frontline staff and patients were unsure about using elements of the systematic approach, and teams used the methods with varying levels of success. So we worked with the teams to transform the methods and ensure that they were both useful and relevant. Our research shows that quality improvement methods help frontline staff translate research into practice.
So I stop it here. So this is what we found. One of the things we looked at is how the organizational culture of Clark, which was about fostering the use of quality improvement methodologies, how it helped patients and professionals work together to improve healthcare. So this is the context of the context where I looked at how participation works. Okay, and I'm going to go back to the presentation now. So in a way, what they were doing in Clark, they were using similar methodologies to PAR, in the sense that patients were working together with professionals, reflecting about which were the problems in the healthcare context, planning how they could improve the healthcare context. So they were then collecting data, identifying problems, collecting data, reflecting upon how to resolve problems in the healthcare services, and then trying to implement changes in services together based on the evidence they had collected through quality improvement methodologies. Sorry. So that's the context of the research, okay? So through our work, we looked at different aspects of participation. We demonstrated that participation is a social process. It's very important to see it as a social process of relationships between different people, where different dimensions are important for practice. For example, we looked at the space and how the spaces where people participate can influence how people participate and relate to each other when trying to improve healthcare. We looked at cultural aspects of the organization of Clark, and we looked at socio-psychological dimensions. For example, how patients who are participating develop identities as participants, and how that can influence how much voice they have when they are participating, how much impact they have. And we've published different papers looking at these different dimensions, and I'm going to go through this. Okay, and yes, okay, so we start with identity. So these are the papers we've published looking at these different dimensions: space, identity, organizational culture, and how patients' conceptualizations of what quality of care means also shapes how they participate and how they feel like they have the right to claim quality of services when they are participating. So, identity. Why identity? Why do you think it's important to look at the identity of participants? By identity, I refer to self-understandings of how participants see their role when they are participating. Well, it shapes what they can do, what they feel they can do when they are participating and when they are interacting with professionals. So we looked at how the social identities of patients, participants, develop through participation, how the relationships that they establish with professionals, with researchers and healthcare providers shapes how they feel about themselves as participants, how much empowerment in a way they have or agency to influence what they are doing. So one of the things that that we started looking at this because one of the things we realized is that in the context of participation there were very different ideas of why patients should be participating, very plural understandings of what the role of participants is. So we wanted to understand how this context of plurality of definitions of why patients should be participating shaped how they felt about their role in healthcare. And this was important because we felt like their capacity to negotiate and shape quality of services through the research and the quality improvement methodologies, it was shaped by how they felt their role should develop. So that's identity, and we're going to look at some examples later. We've also published a paper looking at what happens when the lay knowledge of patients about their lived experiences of illness, of using services, what happens when that knowledge encounters the knowledge of experts, researchers, the technical knowledge, the biomedical knowledge of doctors, the research skills of researchers, what happens with the knowledge of patients? How is it used through participatory activities to then shape research and shape service improvement initiatives? And as I said, we've also looked at the spaces of participation and how the nature of the spaces where patients participate influences how much voice they have in trying to influence healthcare. So as you see, this is looking at participation from the outside, okay? Looking at how the dimensions of participation influence the outcome of participation. So what do you think participation looks like in the UK? How do patients participate to try to influence healthcare services? Do you think it looks like this? Or like that? Or is it more like this? It's actually more like this, okay? So all the spaces that I observed where patients were participating were very formal, very different to the examples you brought to us. They were actually happening meeting rooms in the hospital, very formal, institutional, bureaucratic spaces, which can put people off, okay? And then I'll give you some examples of how and why they might put some people off. Okay, so let's start with identity. So one of the things we looked at is identity making and how the identities of participants are shaped by participatory processes, by the tools used for participation, by how healthcare providers approach them and talk to them, by how they try to elicit their illness narratives and their knowledge to influence healthcare. And what we found, and I'm going to start with why it was important. So government and development agencies worldwide encourage citizen participation. And participation is increasingly framed as a citizenship right, so as a right of patients to influence healthcare. But what it means by involvement, engagement, participation is very unclear and is open to multiple interpretations about the role patients can have in influencing healthcare and about the roles they should be having. And these conflicting justifications for why patients should participate have ontological and epistemological implications. So they have implications for how patients feel about their role, but also implications for the type of knowledge they feel they can bring and they can contribute with when they are participating. So So we found that through the research that there were these plural conflicting understandings of what the role of patient participants were. We interviewed healthcare providers and researchers, and they had very conflicting ideas. In the same interview, I could see how there were tensions in the way how they saw patients should be participating. And then we interviewed and observed patients participating, and we saw how these conflicts, these tensions were enacted by participants, and they were kind of in a way articulated through the way they saw their identity as participants. So the understandings of professionals contain conflicting definitions about who the public participant is, how they should behave when they are in meetings, when they are participating, and what types of knowledge they should contribute with when they are participating. And these conflicting understandings that healthcare providers and researchers have about participants permeate how they interact with them, influence how they invite participants, patients to participate, and influence the identities participants developed. And we found that the patients and the community members that were participating defined their involvement experience and developed their self-understandings through and against how professionals were seeing them. It was obvious through the interviews how they referred back to how professionals were treating them and how they thought professionals saw them. And their identities, in a way, were produced in this way. So, patient participants were seen and treated by professionals as outsider technocrats whose experiential knowledge of their own body and their own condition of using services and living with their illness is very important to improve services. It's very important to know how we can make services better. And this is an example of a quote from a provider. But at the same time, the same professionals were constructing patient participants as somehow lacking the skills necessary to function in this very institutional and bureaucratic context. They didn't have the technical knowledge of research and biomedicine, and they saw them as struggling to function in this very, very bureaucratic context of the National Health Service. And they, at the same time, asserted that patients who were participating, they had to improve their own skills if they wanted to participate effectively, right? So some of them received some training so that they could function well in these environments. So in a way to participate, according to professionals, the patient must fit within the particular expert categories of disease. So they need to bring their expertise as patients, but at the same time they are being asked to be someone else, someone who is a proto-professional, who can also contribute with research skills and biomedical knowledge. So this is very contradictory, because although patients were invited and were asked to maintain their identity as patients, as someone, for example, with HIV, they were participating in an HIV quality improvement project, the patient, paradoxically, is asked to be an expert professional, a proto-professional, and to overcome the shortcomings of having only lay knowledge. Lay knowledge is not enough. So there is a contradiction in how they are being invited to participate. Professionals saw that it was important for patients to be effective participants, to have the lay knowledge, but also to be very good at functioning in this kind of institutional context of the hospital and the university. So, another contradiction we saw, we are here. Did I show you this one? Yeah. Okay, this one. Another contradiction is that when patients were very active and they had a voice, they had agency to try to claim the rights for quality of health and to try to shape things, they didn't like it, professionals. Someone with a strong voice, they didn't like it. So they wanted, in a way, patients to volunteer and to participate, but at the same time, those who had a strong voice were not seen as legitimate participants. So they, in a way, in the interviews, were talking about the importance of patients to be self-critical of themselves, to discover their bias. They saw patients who were advocates for the patient community they, in a way, were seen as non-representative. Professionals talked about them having their own agenda, and it was important that they are neutral. So in a way, there is another contradiction of how they are being invited to participate. They want community members and patients to be active and participate, but when you are too active and you have a strong voice, then you are seen as non-representative. And this is a big problem in the way participation happens in the UK. The issue of representativeness is used in a way by experts and providers to see participants sometimes as non-legitimate, okay, as having a voice that is not good, it's not representative. So in a way, patients were being asked to become institutionalized, reflexive citizens that reflect upon their own biases and where they are not representing their other patients properly. They need to be more neutral when they are participating. And this is an example of a professional talking about that. So then when we looked at how patient participants were understanding their role and talking about themselves as participants, we saw that all these tensions were somehow reflected in their narratives about themselves, right? And we found that in a way, being a patient participant is very difficult and is very conflicting because the positions that are available to participants when they are invited to participate and also in the interaction with experts during participation are very difficult to reconcile for them. It's very confusing. So the identity strategies that patient participants developed were interesting. In a way, they were looking for like similarity with the institutional context. They tried to be similar to the experts and professionals they were interacting with, and they developed a lot of technical knowledge and knowledge of the institution and how to function within these very bureaucratic meetings, how to use agenda items to try to influence what was going on. So they were trying to search for closeness and similarity with the expert majority. One thing I haven't told you is that they were a minority in a way, because they were participating in groups, in teams where there was maybe one or two patients and the rest were all professionals wearing suits and using iPads, or so you can see the picture, right? So it was they were a minority in an expert context. So we found that central to the identity of the patient participant is the situation that they have as an outsider, a member of a minority group who at the beginning is very unfamiliar with the context where they are trying to participate. So, for example, this was materialized in things I saw when I was observing them. So, for example, most of the meetings would be in a hospital boardroom with pictures of clinicians, male clinicians, and professionals wearing suits, and a very formal structure of a meeting where they have an agenda, etc. So you cannot raise your voice unless it's related to the item of the agenda they are discussing. So it was interesting how at the beginning of a meeting, healthcare professionals would introduce themselves with their job title, like I am a clinician, I am a whatever, academic, professor. And then patients would look around thinking, okay, so how shall I introduce myself? And it was very interesting how some of them were lucky enough to be members of a charity, for example, of a patient group, and they use that identity to present themselves, but the ones that didn't have that belonging to another group, civil society group, would just say, well, I'm just a patient, right? So you can see how it was difficult for them. That's just one of the examples. So just to kind of go through it a little bit again. So on the one hand, the patients are ordinary members of the public who are invited to participate and to be kind of critical friends about how services work and how we can improve services. And they are asked to be like self-determined citizens, so to kind of use the right to claim quality of healthcare when they are participating. and they are asked to participate and use their experiential knowledge of their lived experiences when they are participating, so use their knowledge of using services or living with their illness to contribute to participation. But on the other hand, as we have seen, they need to adapt to the norms of the expert system. If they are too assertive, then, or they have too much agency, then they are not seen as representative or legitimate participants. And when they bring lay knowledge that is too personal, too subjective, that has affective elements, then they are seen as not contributing with knowledge that is representative of other patients, right? So you cannot be too personal and or bring emotions into the participatory processes. Okay. So as I said, what they do to try to survive in these expert systems is that they try to seek social recognition in the host environment by trying to develop to be similar to professionals. So I would see patients wearing suits and ties in a meeting, right? And as I said, they would introduce themselves in a meeting, if they could, by using their belonging to another organization rather than as just a patient, right? So when I talked to them, they constructed themselves as working very hard to navigate these expert systems and learning how to adjust to the bureaucracies of the system. And also they demonstrated in the interview, to me, they were talking about themselves as like being very professional and performing their tasks with professionalism. And this is an example of a patient, okay, talking about himself or herself. So these forms of participation were very top-down. They are not bottom-up. They are invited spaces that are controlled by professionals to fit their own responsibilities and culture, etc. So, just to summarize, what we found is that being a patient participant was about struggling to first assert your legitimate identity as a minority expert patient. Second, to survive as a lone outsider in a very bureaucratic, complex system. Third, to exercise agency. It was very difficult for them to exercise agency and to have a voice in contexts that were very top-down and controlled by professionals. And it was difficult to find recognition for their lay experiential knowledge in this context. Okay, so now, unless you have questions, do you have any questions? No? Yeah.
To my understanding, the participants are asked to share their experience. But then you mentioned that they're also expected to share their expertise. For example, if you could...
Yes, so for example, they were invited, so let's say there was a HIV health services improvement project with researchers, clinical staff, and patients invited to be part of the team to improve services. So the patient is invited because they have their identity as HIV patient, and that's why they are invited in the first instance, and because they can contribute with their understanding of how services can work better for someone with their own condition. And then the team is formed, and they participate, and they have like a 1 year or 2 year project. But then, in a way, professionals would also want them to develop skills to try to understand how research is done, to understand conversations about quality improvement. So they used very technical knowledge about, like really technical knowledge that even me as a researcher couldn't understand because it was very kind of health services knowledge. And they wanted, in a way, they wanted patients to be able to also function very well at that level or be trained so that they can function. So they wanted them to have both. But then also when the patient is too personal, I mean, you are invited there because you want them to bring their illness experiences. But when the patient becomes too personal about their illness experiences, then professionals question their representativeness. They are being too personal. They are not representing the rest of the patient community. So all these contradictions, patients were aware of. They could tell by the way the meetings were developing. So it was a very contradictory role. Some patients that I saw were participating for a long time. They were professionals. They functioned very well at the end in this NHS context, and they knew how to use quality improvement language, research language, etc. in the meetings. But others were put off by it. It's not for everyone in the community. This is not so. And this was the context. So it's important that you understand the context so that you can see why this is so we are so critical of the context, right? So these are things for you to think about when you are trying to do participation. How can we create an environment that enables participants to participate and bring their capacities and capabilities in a way that they are not rejected or put off by the way we are doing participation? Is that, yeah?
Thank you.
Yeah.
My question is, were you brought in to look at this because the professionals realised there was a problem, or?
I was brought in because Clark was fantastic. So Clark, the organization, the consortium, they were trying to introduce participation in healthcare services, and they were trying to support professionals to do it, and they wanted them to do it well. So they brought us in to look at what was happening and how, and then we fed back to them things that we observed, and then they changed the approach totally. So it was just for them to know how it works, because it was a very new thing. Yeah.
Because I'm curious if the professionals, clinicians were aware of the problems, or?
I think for them it was a challenge because they were asked to do it, but no one had told them how to do it because it was a very new thing. Clark was trying to support them, but I started at the very beginning when still it was a new thing for them as well, because it's a policy now that they need to be doing participation at different levels: research, service improvement, governance as well of services, and commissioning. Yeah?
Sorry, if your research was running alongside concurrently, wouldn't that have invalidated the work that they were doing if you had called it into question?
What do you mean by invalidating?
So they're doing it wrong. The stuff that they're getting out of it.
In a way, yeah. So in a way, I wouldn't want to say they were doing it wrong. Like, we were not evaluating. We were just looking at how participation works in practice. We didn't want to call it evaluation. It wasn't an evaluation. We just wanted to see how it happens in practice and what are the challenges that people encounter to develop some theory around it. So yeah, so I had lots of people coming to me and asking me. That was one of the difficult aspects of my ethnography, is that I had lots of people coming to me to ask me, so tell me, how is the evaluation going? And I felt very uncomfortable about that because I was just observing how it happened in practice to then try to change things. And yeah. Okay, so I'm going to talk about space now. Sorry. Let me go to my notes. I need my notes. Okay. So, okay, now I know where I am. Sorry. So we have also explored in this context how participatory spaces created for participation and involvement affect the type of participation that happens in these places, and how the participation, how through participating patients can also change these spaces despite the challenges that they encounter. And why do you think we've looked at the space? And what do we mean for a space? What do we mean by space? So we were interested in a space because we saw that in the literature and academic discussions and policy, they were all permeated by metaphors about a space. There was a lot of reference to opening up and widening arenas for participation, and there were lots of references to the context of participation and space. But we thought, okay, but the space, participatory space has not been theorized. What do we mean by that? The spaces where participation takes place, the processes through which spatial elements influence the agency of participants and ability to influence healthcare hadn't been looked at in a way. So we thought, let's look at it, and let's try to understand what is a space in participation. So what we did is we theorized what participatory citizenship is. There's also a lot of reference in the participation literature about citizenship and communities exercising their right as citizens to influence healthcare. And we thought, okay, so what is participatory citizenship and how is influenced by the spaces where participants participate, and how through their participatory citizenship, through how they negotiate the rights for quality healthcare, patients can also shape these spaces. Okay? So, being invited to participate is not enough for communities and for patients to influence, because participatory spaces are managed in a way that create particular social relationships, temporal aspects, and material aspects that influence and limit participants' agency. So in my context, for patients, being invited to help plan and improve health services involves having to fit into NHS organizational cultures. This is in my case. And patient involvement, participation takes the form of participating in committees and board meetings and steering groups. So it's very formal, okay? Formal invitation into these spaces is not enough for patients to act with agency and influence healthcare, because these spaces are very limiting. And the nature of these spaces can hinder patients' capacity to influence and have a voice. So in our work, and I'll go through it now, we saw that despite the limits in these spaces, some very experienced patients that have been participating for a long time are able to change these spaces somehow. They learn how to navigate, and they make participatory spaces more collaborative. And they develop tactics to create, in a creative way, use these very formal spaces to try to improve healthcare for their patient communities. So they try to advocate for their we call it loyalty projects. Okay, so a patient with diabetes, for this patient, the loyalty project is improving healthcare for their other diabetes patients, right? So that's their loyalty project. So they find a way of using these spaces to try to advocate for the rights of their patient communities. So this is when it gets maybe a bit too abstract, but bear with me, I'll show you some examples. So we conceptualize participatory citizenship as a process of engaging with, negotiating, and reconstructing the spaces patients find themselves when they are trying to influence healthcare. So the participatory spaces. So we draw on Doreen Macy's idea. She's a geographer, to conceptualize space. And we understand a space not only as the place, a place where we are, but we look at the space as having three dimensions. One is the physical, the material, the place where we are, the tools that we use for participation, so the material aspects of the space. The other one is the temporal, when participation takes place, with which frequency, at which time, for how long. And then the social aspect of a space, which is the relationships between people, how people relate to each other. So for instance, when participation takes place, the duration and frequency of participatory activities, the settings, the places where participation takes place, the hospital versus the community, for example, or the bureaucratic processes that manage these spaces. For example, these are the tools used for engagement, like is it a very formal steering committee, or is it a more creative photo voice project? All of those, they shape the social dynamics, the interactions between patients and doctors, and affect not only who participates and who wants to be there, but also what is sayable and doable, so what people can do and say when they are at these meetings. So a very formal space might not work for a young person who wants to participate, or might not work for someone with not so much education. So this is why we thought it was very important to look at a space. So participants' voices and knowledge, the type of knowledge they bring to participation, can be constrained by the tools used for involvement. So photo voice or drawing, as opposed to a very formal steering committee, right? And also participatory spaces, they have a history, they have meanings. Patients attach meanings to places. So those meanings can influence who wants to be there and how do they want to be there. So if a patient community is very distrusts or doesn't have any trust on health services, and the participation happens in health services, when they enter these spaces, it's going to shape how patients want to participate there. You might prefer to do that in the community, the home turf of patients, because patients can be very suspicious of healthcare services and experts. So these are things to bear in mind when you are thinking about how to do participation. So we found that patients had to develop very detailed knowledge about the aspects of participatory spaces, so about the National Health Service in this context, the hospital. For example, they learned a lot about the workings of the NHS, so I'm going to refer to NHS, that's the National Health Service in the UK. They learned a lot about power dynamics between clinicians and other clinicians and researchers. They became very good observants. They learned about the bureaucracies of the hospital, and they learned how to navigate these very constraining spaces when they were participating. And they developed some tactics to try to influence healthcare when they were participating. The first one we call plotting. So in a way, they learned how to map out the spaces of participation to try to influence healthcare. They learned how to conform to normative ways of interacting at meetings. They learned about the interpersonal codes of conduct. For example, they learned that wearing a suit was important for the meeting. And we found that despite the limitations of these highly bureaucratic spaces, some patients who were very experienced and were there for a long time were able to map the spaces, and they developed tactics to overcome these constraints to try to make these spaces more collaborative and to try to advocate for their loyalty projects and try to claim the right for quality of healthcare and to try to in a way increase their impact and their influence when they were participating. So, in a way, what we found, another tactic, is the transient combination. So what patients were doing is they were kind of using aspects of these very formal spaces to try to pursue their own projects. So if, for example, with their patient groups, they were advocating for something in particular, they were trying to bring that into the very formal meeting somehow in a creative way. And I'm going to give you some examples of this. So some of the patients, for example, just so that you can understand the context, some of the patients were also members of a charity, a patient charity. And maybe they were also participating in another participatory project in another hospital or in an ethics committee. Some were like CEOs of another patient charity, national charity, or were members of a patient group in the hospital. So they had different participatory experiences that they could use when they were participating in quality improvement, and they brought the knowledge from all these spaces. So, how was participatory space constructed? So, it was constituted through social and material transactions that involved patients doing things for professionals, right? They were invited. It was very top-down. And professional, so the space was very top-down, and it was, in a way, controlled by professionals. Professionals were setting the agenda for participation, so it was not like we were talking about the importance of patients setting the agenda of what is important for them to improve and to change. They were somehow brought into the space quite late in the process, after prioritizing what was the aim of the project for quality improvement. And there was a tendency towards one-way flows of information. So it was always professionals soliciting the experiences and the knowledge of patients, and so they were in control in a way of the space. Patients' opinions and views of their patient communities were being solicited by providers and professionals who were setting the research questions themselves. So it was in a way more like consulting rather than patients being like in charge as well of the process. So there were one-way flows of physical movement. So in terms of like the materiality aspect of a space, where patients were the ones who were coming into these spaces, they were asked to come to the hospital rather than professionals going to their communities, right? And patients' time in terms of temporal aspects, the timing of the events, for how long participation happens, 1 year or two, or when it happens, it was always controlled by professionals to fit their own work schedule. So it happened during the day, during the time when they were working, and at a time that worked for professionals rather than patients, right? So some patients were working as well, so it was difficult for them to come at times when they, they should be at work as well. So that excluded certain communities of patients. So the patient's time was committed to professionals' requirements, but the transient combination tactic that patients developed, in a way, helped patients co-opt elements of these participatory spaces so that these spaces could have new functions for them. They were very clever, some of them. So although they felt like they did not have much control over these spaces, they could somehow use them for their own advantage. They could use temporary aspects of these spaces for their own use to try to improve quality of services for their patient communities, in a way, try to find a way of like introducing a new aspect into the project that would fit the requirements of their patient communities. So one example of transient combination, and these examples come from the ethnography rather than the interviews. So for example, one participant used his participation in a national healthcare commissioning group and in a parliamentary group to raise the profile of a local hospital project, like healthcare improvement project, where he was participating and where he was trying to work towards the improvement of services for the patient community. So the transient combination tactics help participants feel like they were working towards achieving their own loyalty projects despite participating in very formal top-down invited spaces. So they found something they could do in those spaces. Another participant, for example, with disability, accepted an invitation to participate on a service user group at the hospital because it would enable her to gather information, important information, that she could use to report back to the disability charity where she was a trustee. She thought, if I go here, maybe I can gather some useful information for my charity. So they were using these spaces for their own advantage in a way. And then the third tactic that they developed, and these were the patients who were very experienced, is the interconnecting spaces tactic. So once inside these very formal participatory spaces, patients became embedded within them. They were asked, professionals were desperate to find more patients, so they were invited to lots of quality improvement steering groups, etc. So they participated in many settings, research projects, governance boards, research ethics committees, service improvement projects, but also they had their participation outside. So they were members of patient groups and charities. So in a way, patients embodied a web of personal connections. They were very well connected, and they had lots of participatory experiences that they could use tactically to try to make participatory spaces more collaborative and more productive. So they somehow used their connections and their knowledge they brought from these different spaces to try to improve their impact in healthcare. They used, for example, one of the things they used is like they would go to a meeting with lots of clinicians and they would bring knowledge from another hospital about a care pathway improvement project that clinicians were not aware of, and they would try to connect clinicians from their team to the other clinicians so that they could collaborate in the care pathway improvement project and to avoid duplication. So they were very good at this. So they were making participatory spaces more collaborative. And clinicians really used their knowledge because they knew a lot, because they had been participating in so many settings that they could use all this knowledge that patients were bringing. So, one of the things for example, I'm going to give you an example of one of the patients. So, there was one participant who was participating in the service improvement project I was observing, and he tried to speed up these improvements in the hospital. So patients were very keen at seeing how the improvements were being implemented in the hospital. So let's do research, but let's ensure that it's going to be implemented, and let's ensure that it's going to be sustained as well. And also, can we also spread it to other hospitals? So they were very good at advocating for this. So he tried to expand improvements to other hospitals by creating links between the different hospitals, because he was participating in a steering group in a hospital and in another one. So he created these links between these different hospitals so that they could share knowledge about how to improve the care pathway. So he shared information between the two teams because it was important for him to avoid duplicating efforts. But he also used information from his patient charity that could fit into the care pathway. So he brought knowledge from his patient charity to improve the care pathway. So in the charity, they had developed some kind of self-management leaflets, and he gave them to professionals, and he said this is important for the care pathway. So they introduced that into the service as well. So he was interconnecting in a way the two service improvement projects with the charity he was participating in to make it more collaborative and productive. But not only that, for him it was very important to ensure that after the funding period of the quality improvement project, this new service was going to be sustained and it was going to continue being implemented. And he knew that so projects would finish after the funding period, and the hospital wouldn't have money to continue doing this new service. So he thought, if I go to the community and I tell all my patient community that there is new service, maybe they come and they demand and they ask for it, and then they had to keep it. So he also raised awareness about the new service in the community to ensure that the project would continue after the funding period. So in a way, these interconnected tactics reflected the aspirations that patients had to increase the speed of implementation of healthcare improvement interventions. They wanted to ensure it's not only research, we need to have an impact. We need to ensure this is translated into an improved service. And their interconnecting tactics also reflected how patients wanted the interventions to spread to other hospitals so other patients could benefit from these new interventions. So, we have also looked at how knowledge develops through participation. So we looked at what happens when the knowledge of patients, the lay knowledge of patients, the lived experiences of patients meets the knowledge of professionals, the biomedical knowledge. And research, biomedical, also experiential. But so how do professionals, researchers, and healthcare providers use the knowledge that patients bring? Okay? And what we found, or what we looked at, is how, in a way, how professionals try to articulate the subjective aspects of patient knowledge, and how do they use that subjective aspect and try to make it more objective, right? It's the tension between subjective experiential knowledge and objective scientific biomedical knowledge. And this is in tension for them when they are involving patients, okay? So participation involves the encounter between different types of knowledge. The knowledge that professionals bring, which is evidence-based, biomedical, research knowledge, experiential knowledge as well of providing care, and then the lay knowledge of patients. And in our paper, we look at how these different types of knowledge engage with each other in participation. So we know that in the course of their work, professionals develop different types of knowledge. And it's hybrid as well. It's not just expert knowledge. It's experiential, it's biomedical, it's evidence-based. They navigate scientific facts and clinical guidelines. They use also their own accumulated personal experience. Also institutional discourses, policies come into their knowledge, so their knowledge is hybrid. So what happens when they meet patients through participatory practices? How does their knowledge change in a way? Because in a way, participation of patients, participatory activities, provides another context through which professionals' knowledge develops, and we wanted to look at that. So what we find about professionals' knowledge, so the knowledge of professionals when they are working with patients through participatory activities, is that in a way professionals seem to be instrumentalizing patient experiences, right? And they wanted to remove the subjective elements of the patient experience and so use it in a way, the knowledge of experiences that fitted their own hierarchy of knowledge, values, or something like that. So in a way, professionals appear to be welcoming patient experiential knowledge of their illness and their bodies, because this was important to improve care pathways, for example. You need to know about experiences. But they also were looking at sanitizing and abstracting the experiences from patients' biographies. They were instrumentalizing experiences, and they were privileging, in a way, disembodied forms of knowledge. So they didn't want patients to bring their emotional, embodied experiences into their kind of knowledge they were contributing with. So these forms of participation, in a way, professionals were requesting patients not to be too personal, not to be too emotional. It gets in the way, right? It's not objective. So that's what was happening, the way they were using their knowledge. And this is an example from a quote from a professional. Yes, shall I move on? I have another one. Yeah? Okay. Yeah. So professionals did not value patients' subjective, private experiences as a source of evidence. It's not a good source of evidence. They ask patients to transcend the very same illness and healthcare experiences that they had led them to participate and to be invited to participate. So this is another contradiction, similar to what we were talking before. So in a way, in the way they were using patient experiential knowledge, they were trying to re-articulate it by bringing elements from research and biomedical knowledge and trying to make it better, right? So, for example, professionals refer to the shortcomings of patient experiential knowledge as rooted in causes of recall bias. So it's like they cannot be representative. They have recall bias. And they often talked about representativeness, which is something that comes from research, right? And this is another example from a professional. Okay, Have you finished? Yeah? Okay, sorry. So in a way, the professionals who were involved in patients in participatory activities, they position themselves as regulators of the lived experiences of patients. They were like in control of, they wanted to control it as a form of evidence. So they could regulate patient experience as a form of evidence, and they drew, when they talked, it was very obvious that they drew on the authoritative voice associated with medicine and clinical guidelines, etc. And they often talked about finding mechanisms to manage and manipulate patient experience narratives to remove them from subjective aspects and to make it as a better form of evidence, right, to improve services. So they were, in a way, wanting to distill patient voices from subjective noise, we say. And this is another example of the contradictory demands that patients are given when they are invited to participate, right? This contradictory, the type of knowledge they're asked to contribute with. So this is something for us to think about when we invite patients and we work with patients. What do we want from them? What type of knowledge do we want from them? Yeah? Okay. So very quickly, because I'm over the time, we've also looked at the organizational aspects of Clark as a quality improvement organization, and how the organization of Clark as kind of modeling behaviors of collaboration and teaching quality improvement methodologies, and all the time like making emphasis for teaching is not the right word, but like encouraging researchers and service and providers to use quality improvement methodology and to collaborate in multidisciplinary groups with patients to try to make sure that the evidence gathered through research is implemented very quickly into better services. How that culture that was really very well communicated by Clark helped patients become more engaged in their participation. So we looked at I'm going to go quickly. So we looked at how patients used aspects of that organizational culture to try to understand what was their role and to feel like they were more engaged in their team. So they really liked how Clark was modeling a culture of which was very horizontal and very multidisciplinary. Clark also as a program had patients in the program involved, and they were modeling patient participation very well. The quality improvement methodologies that Clark used were like the plan, do, study, act, emphasis in making sure research evidence was very quickly implemented into services. And for patients who had been participating for a long time in other settings, they really liked the fact that they could see how their input was being used to change services, because for a long time they were participating in groups or teams where they were like really kind of more like consulting them, and they could never see how much impact they had and how their input was used to improve services. So in a way, in this paper, what we talked about is how the patients end up in the meetings. I observed them using the quality improvement discourse, and they use quality improvement language to try to make sure researchers and providers were collaborating and to ensure that the changes, the evidence from the research was implemented. So that's what we look at in the paper, is the organizational culture and how it's used as resources for patients. It's a resource for collaboration for them. I think because I've gone over, I'm not going to talk more about it, but just to tell you very quickly, we've also published other papers around participation. One in which we look at this one, we look at how patients' understandings and definition of what quality of services is shapes how they participate and how they try to influence healthcare. We've we've done a commentary on co-production and what it means. In the UK now, rather than participation, they talk about co-production, and so we've kind of discussed that. And we've also done a systematic review where we look at community participation and aspects of community participation that influence improvement of services for maternal health as well. So all the references are, and then I edited a special issue on citizen participation in neoliberal times, where we had contributions from different disciplines looking at participation in general, not only health. Thank you very much. All the references are here. Do you have any questions? And And this is the most abstract I will get today, I'm sorry. I thought better in the morning where you're awake. But these are important critical aspects of participation we need to think about when we are involving communities and patients. Do you have any questions?
Alicia, it's not a question, but I just want to say that I was very interested in, how the clinicians treat the patient in a way. Like, they actually expect the patient a lot, Your subjective experiences, yes, not scientific enough in a way. So it's like the knowledge doesn't count.
Yeah.
No, it doesn't count. Although, yes, you can say that, you can express that,
yeah.
but it doesn't really count.
Yeah.
Yeah, so I'm thinking in terms of, one theory that called authoritative knowledge that was written by Bridget Jordan. But she used it in childbirth, yeah?
What's the name, Bridget?
It's called Bridget Jordan. Jordan, Jordas. And her theory is called authoritative knowledge. And she said that, knowledge is important. And lay people like us, we all have knowledge.
Yeah.
But then when we deal with healthcare, it doesn't count.
Yeah.
Because they think it's not scientific.
Exactly, yeah.
That's really interesting when I read those things in your papers.
Yeah. It came very clear how there is a hierarchy of evidence and how the subjective evidence, which is a form of knowledge in its own right, didn't count alone and had to be regulated and changed to count as a...
Yeah. And when you think in terms of evidence-based healthcare,
Yes.
see where this subjective knowledge doesn't count.
Doesn't count at all, yeah.
It's not important.
So what do they, sorry.
Yeah. Who? Steffi or? Yeah.
No, just really quick comment following on that. I think that's really important because in my experience, sometimes now with different grants, for example, it's kind of like you almost need to tick the box that you've had some sort of involvement or consultation with different people, and it's like, how do you make it not tokenistic, but you make it meaningful, and that you're not just eliciting views for like the sake of ticking the box, but then how does it integrate into either a program you're developing, or and also then like how much do you take on board, and at what line do you say, well, we can't take everything?
Yeah.
It's kind of a tricky.
It's very tricky, and I think because sometimes participation is, well, now we have to do participation in our research as well. Some funders require we do it, so it can become very tokenistic and a tick box exercise if you don't think about it clearly. Yeah.
My question is also related to this point, that it felt at some point that the clinicians are kind of being selective of what they want or what they choose. Like, isn't that a problem, or is there a certain approach for that?
What do you think?
Yeah,
It's common.
they're picking and choosing what they like.
Yeah.
Right? So what are you doing with the stuff that it's like they don't value what's coming unless it fits within their scope. So why ask?
Yeah.
That's right.
It's unethical, right? It's people's times and people's lives. I mean, they were very good examples later on of projects that were very patient-led. So things change over time. I've been now presenting the beginning of it. Thank you for your very interesting comments. So shall we have a break now?